Welcome everyone to today's webinar. I'm Molly Gamble, Vice President of Editorial and Editor-in-Chief of Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We're looking forward to hearing your questions. Additionally, in about a week following the webinar, we'll be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Brant Jewell is a director with Prism Healthcare Partners, a national healthcare consulting firm. Brant focuses on physician operations and health system strategy and has extensive experience assessing executive leadership, physician alignment strategies, clinical quality and efficiency, technology capabilities, and competitive landscapes for health systems across the country. Brant partners with health systems and medical groups to develop operational solutions and strategies that improve the organization's financial health. He has also worked on value-based care strategies for integrated networks of employed and independent providers. Mary Baker is Chief Clinical Operations Officer of ProHealth Care, the healthcare leader in Waukesha County, Wisconsin, and surrounding areas. She joined the health system in spring 2017, bringing over 20 years of leadership, strategy, and physician integration experience. Mary is responsible for oversight of the strategic, clinical, financial, and operational performance of the ProHealth Medical Group in the Dyad model. She's also a member of the senior executive team with responsibilities relating to the system service lines and professional nursing care across the organization. Prior to joining ProHealth, Mary's most recent role was Vice President with Indiana University Health. In that role, Mary worked closely with the system senior leadership to transform and expand the system from 5 to 18 hospitals. Mary received a master's degree in both nursing and health administration from the University of Kentucky and a Bachelor of Science degree from Eastern Kentucky University. Brant, to get the conversation started today, I'm going to turn it over to you and ask if you can tell us how you define patient access.
Thanks, Molly. And before I answer the question there, I'm going to give a little bit of context for how Mary and I began our work together and how we've been successful and learned things along the way. Prism was engaged with ProHealth Care to do an assessment, for a broad-based assessment of all operational issues in the ambulatory setting. And Mary joined basically at the conclusion of that assessment, right as we were beginning to pursue our recommended implementation items. And so she came with a fresh perspective and a lot of positive momentum for change. And so I think that's been a key ingredient here, and the success and her being able to objectively partner with us and the things that we had highlighted in an assessment to then jointly pursue. And she's been exceptional in achieving those results. Today we're going to discuss a lot of what we've worked on together, both solutions, identifying the problems, quantifying the problems, and then we'll give examples of things that have worked and things that we've learned along the way. And I'm privileged to partner with Mary on this, and again, we appreciate you taking time to be with us today. For the purposes of our conversation today, we're going to define patient access both for the patient as well as the provider. For the patient, simply, it's the ability to access the care they need in a timely manner. On the provider side, we'll refer to patient access as how the provider practice manages those patient touch points and schedules to coordinate service access and minimize wait times, delays, and excess work. So we're going to discuss how providers and medical groups can work together to improve the access to care, reduce patient wait times, better manage those provider schedules and templates, and enhance the visit slot utilization across the ambulatory enterprise.
Great, thanks, Brant. And then, I imagine somewhere along the way, and it's probably good to acknowledge this up front, but in this conversation, the challenges associated with improving patient access for individual providers and medical groups. Mary, do you have some insight on these challenges? Can you tell us a bit more about what those look like?
Sure. As Brant shared, I brought a fresh set of eyes to the process at ProHealth Care. Access had already been jointly identified as a key opportunity by both the leadership of Pro Healthcare and Brandt's team. In addition, our competitors had really started expanding their footprint into our market. Historically, we've been the dominant provider in our entire service area. It was essential, therefore, that we take quick action to protect our market, really support our growth, and ultimately drive revenue to the bottom line. Some specific challenges that we encountered here at Pro Healthcare included a number of elements. Our greatest challenge probably was our provider engagement survey results. A survey was done right before I onboarded, which demonstrated substantial levels of burnout and required that we really jointly address the impact of this as well as access at the same time. In addition, the providers had a really strong desire for control that really played out and was evident in their highly personalized template preferences. And we found some really inconsistent utilization of data and definitions that resulted in variable approaches to practices, that whether they should be open or whether they should be closed as a panel. Our limited infrastructure really impeded our ability to support analytics and decision making. And Brandt's team, frankly, had to do a lot of the heavy lifting as I onboarded to help us really have some data that could be actionable. And finally, our own lack of technology and metrics didn't really position us to track improvement successfully. Many of these challenges, however, are probably quite common. So Brandt, perhaps you can share some of the challenges that you typically see across organizations as a whole.
Absolutely. I think the data issue is one that is always a hurdle in getting started. Even organizations that have service access data typically have different or varying levels of quality, both on the input side of that data and in the analytics side of that data. And so setting a new baseline and understanding what metrics are actually accurate and what they're telling us, particularly for those that are inputs at the client delivery site or level. The other thing that Mary touched on that I think is worth restating is that culture of managing patient access as an individual provider or maybe an individual clinic. And often as medical groups and employed enterprises grow, they're adding independent practices or acquiring physician practices and adding them into their network. And we often step into situations where there's not a coordinated approach to managing access at the system level, or even at the specialty level in many cases. And so a lot of the work we do out of the gate and what we've done with ProHealth is to set a new standard of data and analytics and how we use that data and the information, as well as changing the culture to patient access as an integrated network as opposed to my personal patient access or Dr. X's personal patient access. So I think those two elements combined with some of the things that Mary mentioned are initial challenges that prevent a lot of organizations from even getting started on this work or having an idea of where they would go first to address patient access.
Great, thanks, Brandt. Thanks, Mary. Moving on, you mentioned a lot of challenges here. So the inconsistent data about utilization, provider engagement, Mary, that was an obstacle you encountered. Lack of technology, a non-coordinated approach to access across the system. Are there any other drivers of restricted patient access that are common, in the healthcare space? And maybe it's worth mentioning any others that you feel should be added to that list. And I'm also curious about the impact provider schedules and templates do have. Brandt, can you talk to us a little bit more about that?
Sure. So as I mentioned, that culture of independent practices and as groups grow, acquiring different operations and trying to merge them together leads to a lot of variability. And so one of the key themes of our discussion today will be around developing consistencies. And it doesn't mean we have to standardize everything, but just having consistent metrics, protocols, definitions will help the entire organization better manage some of those access points. One of the things that is a key driver, and maybe the most key driver of restricted patient access, is just scheduling templates and provider preference. As Mary alluded to, when we got started with ProHealth, we saw a number of very restrictive preferences. A lot of times they've been developed over time for good reason, by a provider or by a practice. But that also leads to some of the restrictions around complex scheduling rules and algorithms. So those are the you can put a patient here, but you can't there, or only at these certain times can this type of visit be booked. In a vacuum, those aren't problematic, but when you start to manage over a large group, or even in a group of 10 primary care physicians, that variability makes it really hard for scheduling staff, clinic staff, and others to support and manage those schedules. On the note of staff and their involvement, we see a lot of groups that are, and providers that are particularly hesitant to give up control and empower the staff to manage their schedules on their behalf. So that leads to a lot of checking with the provider or checking with the nurse to make sure we can fit a patient in, or that we don't do something to mess up a provider's schedule because of these complexities we've already discussed. And finally, a key driver we see a lot are these challenging patient populations, where whether it's in a certain geographical area or whether we segment off people with high no-show and cancellation rates for whatever reason. It could be specialty-oriented or just a uniqueness to that system. But we actually target and manage those populations like you would a disease state in some cases. And so all of those combined, I think, contribute to a lot of the restricted access and the inability to fit patients in, which contributes to that feeling. We've included, if you'll click again, Molly, an example here of just what we're talking about with some of these points. We picked this because it indicated several of the restrictions that we mentioned here, but it's a single provider schedule for a single day. And as you can see, we've highlighted here where, because of predetermined visit slots and confusion on behalf of the scheduling team, that top example is a patient was put into a slot in the middle of a time frame that ended up leaving 2 unusable slots on either side based on the visit links for this provider. So now we've taken up almost double the amount of time we needed to for a single visit, and you can see what the entire morning of visits looks like in a primary care setting, certainly less than what we prefer to see. The second example there is something we see a lot, where the appointment notes or the scheduling information doesn't allow for the clinical staff or the frontline staff at a specific location to understand what the real reason for the visit is, or provide enough information for them to move it around or manipulate that visit as things change in real time. And then the other example we see a lot, in addition to just restrictions on scheduling types and appointment lengths, et cetera, these standing blocks of physician time, and we'll get into this here in a few slides, looking at unbookable time and unavailable hours that should be patient contact hours. And again, when you look at it at one provider or one group, it sometimes doesn't seem to be meaningful, but over the course of time, as those add up, and then across a larger group like at ProHealth, it became a material amount of time for us to try to open up. Mary, what have I missed here that you think is relevant from our experience at ProHealth?
Thanks, Brent. To build on what you shared, I think we've seen access restrictions in ProHealth care occur for some of those same reasons, but some unique ones as well. As I noted, personalized templates and session limits, they're often the result of a provider's desire for control, to have some kind of say over how their day is going to flow. Some of these templates at ProHealth care were pretty extreme, to the point that a few actually felt like they were limited to the first Tuesday a month from 10 to 12 when maybe the moon was full. And I say that somewhat in jest, but somewhat in reality. That really created some severe access constraints regardless of the provider's productivity or panel size. Our utilization as well of subjective and variable approaches to looking at the provider's practice and should it be open or closed to new patients resulted in some really busy providers being open, but with absolutely no slots left on their schedule, while lower volume providers who had open slots were actually closed and not available to new patients needing access. This impacted not only the ability to get in, but the provider's actual productivity and their subsequent compensation. At about the same time, we had been launching through a centralized access center project, and it had many positive attributes for the organization. When I arrived, I would say that it was 2/3 implemented across all of primary care. The challenges, however, of implementing that model before addressing the personalized templates made it really difficult for schedulers to find patients a timely appointment. They would literally have to search through appointment and counting certain things by hand to find it. And then that meant that the patient who was on the end of the phone had a really lengthy hold time while the scheduler was literally just manually searching the system for the availability. And then finally, we had sort of a unique unintended consequence. We've been very successful participating in risk-based contracts. That's resulted in some higher volumes than you might normally see for annual wellness and welcome to Medicare visits. And in that area, we've really outpaced the national norms. And while that's really gratifying and valuable from a population health standpoint, those longer visits really squeezed out some of our traditional minor appointments and follow-ups. That resulted in patient dissatisfaction and an unexpected shift of visits, especially those minor ones, to our urgent care settings. So definitely not a satisfier to our patients and really created some unique challenges for us. So Molly, now that we've talked about some of the drivers, maybe we could share some of the benefits that they'll see by working in this area.
That'd be fantastic, Mary. I think, it'd be really nice to understand the benefits for 3 major stakeholders: patients, number one, and then providers, and also just for the overall health system or hospital where these improvements were implemented.
Great. Thanks, Molly. If you'll advance us to the next slide, we have a graphic that I think to share with the audience that'll be beneficial as a takeaway. For patients, the benefits of improving access really include having that improved satisfaction for easier and faster access to the services and the communication they need. At ProHealth, we knew we were doing something right when we heard the numerous examples of surprise and frankly delight of patients at being able to get an appointment when they wanted. This was a real indication of how complex our access had become. We've also observed shorter wait times for patients to see their provider or a particular specialty, which then also leads to greater loyalty by that patient to the healthcare system. And we increase the patient's ability to see their provider on the same day for a possible appointment versus being automatically referred to the urgent care center. From a hospital and health system perspective, there are several essential elements that can lead to benefits of access. Increasing the revenue with minimal to no additional expense is obviously critical. In today's world of doing more with less, we're all striving to have the ability to expand without adding a provider or adding that additional MA or RN, and that process was a real home run for us here at ProHealthcare. More efficient utilization of the providers and staff resources has really given us a lot more predictability of our volumes and productivity, and frankly made it even easier for us to look at our staffing matrix and models. And we've got consistent data now that drives strategic growth and decision-making, including what is our distribution of services, where are we meeting demand, where do we have new demand that we've not been able to achieve. And finally, we've tried to make this process with the team as provider-centric as well, so that they understand we're focused on the patient, but we really want to benefit them. So we've had them engaged and at the table, and I think we're seeing the fruits of that work because they have more balanced schedules and their satisfaction has risen in the flow of their day. In addition, we now have the ability to make adjustments or facilitate appointments without constantly sending them messages on Jabber or interrupting their day with urgent and same-day needs. We've also been able to have higher slot visit utilization, so we've got less downtime in the individual clinics, but also then the provider's productivity has risen, translating to improved compensation for them personally. And then fewer scheduling errors are happening. We have to go and tap the provider less or their clinical team for input. We have the ability, thanks to the auto releases and some key patterns and appointment types we've really limited ourselves to make that process much more flexible. So Brent, based on your experience, perhaps you have some additional insights related to the benefits of access.
Thanks, Mary. I think that's a pretty comprehensive list by organization or patient or provider there. One thing I think is important is how is the relationship of those groups and patient access. One of the things that this really changes is it sets a new precedence for how all all of these groups handle access and care within a system or a community. And so part of the value that's created here is clarifying the expectation. And so the health system is no longer getting angry phone calls or touch points that create more questions and lack of understanding about why we don't have access. Providers feel more empowered and more confident that their staff are able to support and manage their schedule independently. They're seeing less dropped visits, higher slot utilization, productivity goes up, satisfaction, and patients are now seeing a cleaner line of communication. They know that they can get in to see the provider they want and access the care they need. And so you're really establishing a new paradigm for how care is delivered. And something I think that's of value to the providers in the organization is with this new understanding and being able to marry the data and the operation and eliminate that confusion, you're now in a better place to make some of these strategic decisions about, do we need to grow into a certain area? Do we need to consider shrinking in a certain area? Do we have the resources in place to support these practices and our providers? Are we delivering the right amount of care to this patient population? So I think this really gives you a platform to make some bigger strategic decisions once you've wrapped your arms around all the different things that go into managing patient access.
Thanks, Brand. You know, one benefit you both discussed for hospitals and health systems is increased revenue. Let's dig into that point one bit more. Brand, how can organizations enhance revenue by improving patient access?
Yeah, this is a key ingredient, particularly as you consider investing resources in developing solutions around patient access. One of the key elements of improving patient access is having a return on that work, because it's not easy and it consumes time for providers, administrators, and staff alike. If you'll click to the next slide, Molly, we have a visual that's pretty simple and probably what you would expect. As patient access is managed more effectively at the provider level and at the system level, we see higher utilization of visit slots, we see fewer vacant slots, and those simplified templates and schedules allow staff to more effectively manage and get patients worked in. So we see patient revenue go up in terms of productivity at the provider level, and then we also see staffing expenses go down, particularly with a move like ProHealth, where you go to a centralized environment. That can be a catastrophe if you don't have clear scheduling algorithms and rules and consistent visit types and lengths, et cetera, that we've mentioned. But if you've got all those pieces in place and you centralize staff, or you just begin to pool resources in a smaller environment, less formal centralization, you're able to support more providers more effectively with less resource. And so essentially we're seeing reduced expenses and an increase in that patient revenue for greater net income. Ultimately, we tie revenue to the additional work RVUs generated by that access improvement. And so as providers become more productive, we're able to see a tangible revenue increase across the board without asking providers to increase their clinical FTE or open up additional time, but just using the existing patient contact hours, you can increase revenue and decrease that staffing expense. And Mary, do you want to comment on the financial improvements at ProHealth, and then maybe I can give a couple of other examples for perspective here?
Sure. So I really feel gratified that we've seen some real results and some tangible benefits. We know that our statistics tell us that we have increased access for new patient growth. We have the slots and we have the actual numbers of new patients that we can validate that with, translating to new revenue. We know our slot utilization has improved, very specifically tied, in fact, to one initiative that we did where we allowed providers to choose between a 10-20-40 appointment pattern and a 15-30 pattern. That gave us a real opportunity there. And our satisfaction almost immediately went up after we implemented our improvements. And we all know that if our patients are satisfied, they're going to tell people that they're happy and they're going to refer and recommend. And we saw a substantial reduction at the same time in our third next available So several appointment times became immediately apparent that we had made a real switch in a positive direction. And we're also able to define those objective criteria that lets us evaluate the status of a provider's practice, which has become my team's real go-to for a variety of topics. So Brant, maybe you can share with them the benefit model that you helped us create to look at revenue within ProHealth.
Sure. And with those changes Mary referred to, particularly with the visit length adjustments, across 75 primary care providers, they created at their own selection. You know, this was not the organization pushing them to shorten visit lengths, but just to give the providers a choice and let them dictate within certain guidelines how their schedules are organized. It created an additional 13,000 plus visit slots annually across those primary care practices. And with ProHealth, we're targeting about just over 2.2 million in financial benefit as a result of the patient access work. And we're really still in the middle of tracking that. And we've had several different models for posting that benefit and understanding the value, the financial value of the work. But the ultimate driver is, as I mentioned, the increase in productivity. We support that with some metrics that we're going to get into in a minute that help inform the comprehensive picture of patient access. So it's not all just productivity, nor does productivity is productivity the end all for patient access, but it does really inform that decision. And when you have multiple data touch points, you have the ability to paint a clear picture of what's working and what isn't, and where there's additional opportunity. Just for perspective, other groups around the country that we've seen pursue patient access opportunity, one that's pursued a lot of the same work as ProHealth, roughly 80 employed providers in the Midwest implemented 2.5 million of annual benefit with their solutions. And another group in the Northeast with over 200 providers achieved $3 million in financial benefit, primarily just focusing on no-shows and cancellations, as they'd identified that as the key issue for their patient access constraints. So there's certainly financial return and it can be demonstrated, but we like to track a suite of metrics and not just a single point to validate the financial value.
That makes sense. Thanks, Brant. You know, we've talked about so far the drivers of restricted patient access. We've talked a lot about the benefits of expanding patient access. We just came off a deep dive into how it affects revenue. I'm hoping, Mary, that you can tell me a little bit more about the pages in your playbook and how you work to accomplish improved patient access at ProHealth. So which specific strategies and solutions did you see really lead some results to your organization in regards to patient access?
Sure. So if you'll click us to the next slide, I believe Brant and I can share some key strategic takeaways. We're going to tag team these because I think there are a number of strategies and solutions that organizations can use to improve access. First, you can certainly enhance the provider scheduling efficiency with consistent criteria and protocols. If you have that consistency of the visit links and those standard definitions, as you noted in your entry question, it ensures everyone is using the same playbook and is following the same guidelines and processes. And if you can really simplify those algorithms and restrictions within each specialty, it makes the process easier at all levels. And adding some rigor to that as well is how often can those items be changed? You know, at ProHealth, that's no more than quarterly, helps keep this process sustainable, which is essential as we want to be able to do more things online in the future. And then strengthening our documentation. That really facilitates more efficient visits and ensures the team's aware of the reason behind that visit. In one of the earlier examples Brant shared, there were multiple different patient appointment links on that schedule for that provider, all for a med check. So what are we med checking? Is it really something unique to their diabetes? Do they need more time? Are they a complex patient, or we really just need a regular component of time? Secondly, you can better utilize scheduling resources to manage your provider schedules. Cross-training staff and providing layers of scheduling support allows redundancies to exist, especially during periods of really high demand. You know, flu season hit us this year, and a lot of the refinements we had made allowed us to be able to flex between our contact center and the individual providers' offices to take on extra calls or pass them back, and that wouldn't have been possible in our earlier processes. We also empowered the schedulers to start making decisions, reducing that need to come back and avoid and interrupt the provider that day. That gives them more satisfaction. They didn't really enjoy that part of the process, and it allows the provider to continue to care for their patients without those interruptions. And as Brant shared, having some degree of centralization really is essential if you want to optimize your scheduling throughput. No matter how efficient a particular office is, they can never really prepare for the volume of calls that may happen at dedicated periods of time, whereas a contact center with those redundancies can support those processes. And third, you can reduce an unbooked appointment slots and gaps on the provider schedules. By establishing clear protocols for canceling clinic sessions or slots, you avoid those unexpected gaps that Brant alluded to earlier. And at Pro Healthcare, what we really created was a limited set of codes that could be utilized for that, which then allowed us to not only track the trends, as well as the resources that are being used for other key things like committees or structures that we want to know how many resources are we spending on that, and is that the best use of the organization's providers' time. Removing those unnecessary holds and blocked patient contact times as well optimize the slots without adding any additional resources. That really led to some new responsibilities at Pro Healthcare, where our site leaders review and release those in advance, and then we monitor and track what those processes look like. And so with that, Molly, if you'll advance the next slide, Brant's going to share the remaining.
Yeah, so thank you, Mary. These next few are in addition to the scheduling and template management solutions that Mary just reviewed. Some of the other things that we've implemented with ProHealth and elsewhere are around a consistent practice closure policy, and Mary's going to review a tool that has been particularly helpful at ProHealth here in a few slides, that it holds providers accountable for the time that and the patient service that they've agreed to, and it also has consistency and takes away any ambiguity about whether someone's accepting new patients or when they accept new patients, and how often they're agreeing to see patients. So that tool has been particularly helpful as an objective criteria point to inform decision making. The APP utilization and protocols is increasingly problematic or area of opportunity across the country, as more APPs have been placed in organizations for a variety of reasons. We saw at ProHealth that there were dozens of different APP models in play, and some of those were within the same specialty. And so whether you're using an APP as a glorified scribe or as someone with a patient panel who's seeing patients and doing full schedules on their own, there needs to be some consistency and some protocols that the organization feels are in line, so that you're getting the most value out of those resources. And I think a lot of organizations have added them to help, whether with patient access or productivity or any number of issues. It's important to make sure that you're getting the value out of them that they should provide. It also helps you inform you about what you need and where you might benefit from APPs as you grow and expand services. The third item there is the no-shows and cancellations that we talked about before. We see frequently that organizations, between their no-shows and cancellations, depending on how they define each of those, they'll end up touching every patient visit at least twice before the patient's actually seen in a clinic. And sometimes it's significantly more than that. To give a sense for the magnitude, it's the amount of time staff spend calling each other, calling to make sure that they can fit a patient in or reschedule a patient for a certain time, calling patients back, and that entire communication chain, whether a call schedule has been released in time to put a patient on, or if we have to manage a recall list, all of this contributes to staff time being pulled away from activities that you'd prefer to have them working on and being more proactive with managing those schedules. So that's a key area that we've seen a lot of opportunity in across the country. The last one here is not last out of priority, but we want to spend some more time going into it, and that's about how we engage physician leaders in the organization. And the way that we've done it at ProHealth being a very successful model, and we're going to dig deeper into that here in the next couple of slides.
So Molly, if you can switch to the next graphic. Brent alluded to that we created a practice assessment tool. This is probably one of the most beneficial things that have come out of the ambulatory care redesign process we've been embarked upon. You know, we had a performance improvement team that we chartered. We put together a group of administrative executives and physician leaders, had them think through what the processes might be. The actual tool itself prints out on an 11 by 17 piece of paper because it has a number of categories, but there is certainly a weighting and a scoring process, because what we wanted to try to get at is how do you address the acuity and how do you address the fact that as providers panels get larger, what is that early warning sign that when's their third next available? We had a really engaged group of people who worked on this. As they refined it, we pressure tested it further. We've gone through a couple iterations, and I have to confess that I really love this tool so much now. It is typically pulled out on my desk and used anywhere from 3 to 4 times a day because it's applicable to so many other things you're doing. And it's probably not something that we would have pursued on our own if Brant hadn't been trying to partner with us on how could we improve access. So it's just really a fortuitous and an unexpected benefit that came out of this process that's going to help us tremendously in every feature of our management.
Thank you, Mary. You know, I want to pick up on something, Brent, you just mentioned. It was one of your last points, which is about physician engagement. And Mary, you had mentioned that one of the largest challenges you encountered early on in this effort was a low physician engagement survey result. You had some troubling findings there that you had to address and eventually turn around. So you really speak from experience for my next question, which is for you, and that's how can organizations engage physician leaders and administrators to implement sustainable change?
Thanks, Molly. If you'll advance us to the next slide, I think that we can kind of talk about what our structure looks like here at Pro Healthcare. One of our mottos of this process has been is this is not someone else coming in and telling us what we have to do, and this is not someone doing something to the physicians. This is something the organization is doing with you as a physician and a provider, so that we can partner to meet the needs of the patients. It goes back to making it patient-centric. Yeah, I was very, very fortunate as I onboarded that there were some existing teams already and structures that I could just add additional physician representatives to. That really allowed us to integrate our access efforts into process improvements that were already in progress, accelerate our work, and then leverage so that that burnout issue could be addressed through engagement at the same time, because we really viewed them as married hand in hand. Brant and I both sit on the organization's executive steering committee on the top left-hand side. That steering team is for ambulatory throughput and provides a monthly update to our senior leadership on our progress. Just below that is where some of the key critical strategic thought processes are happening in our steering team. That's a multidisciplinary team with colleagues from all the key segments like revenue cycle, population health, care management, the medical group, and the Centralized Access Center. This was already an existing team. A critical step for us, though, was to help them understand the why we were asking them to pause some of the original work they were focused on, like standardized rooming processes, et cetera, and we needed them to make access their top priority. So help to communicate that why at Pro Health, we shared with them that we had seen a real shift in our visit volumes over several years from primary care to urgent care, and that we'd seen a real trend with associated patient dissatisfaction. And that was accompanied by a decline as well in new versus returning patients. In addition, our community was growing, and we needed to find a way to be able to respond to the growing needs of the community and address their care needs. And we also needed to position Pro Healthcare to be able to expand online scheduling to full open access, because in the future, that's how work and scheduling will be done, just like it is with the airline industry. So right below that on the left-hand side is our ambulatory care redesign operations team. That's really where the providers get to get engaged at a really high level, make sure that they're knowing what the actual process improvements are that are being discussed, bringing new ideas and innovative fresh thoughts to the table, which included working on the session limits, the templates, the open and close practices, If we needed a task force like we did for the practice assessment team, we formed one for a short duration for a complex topic, and then we brought it back out to the bigger team and said, you know, pressure test this, tell us what we did right, help us fix this and make it better. On the right-hand side of the page, it's really what our operational paradigm is that already existed within ProHealth's medical group. We leveraged that and had them focus in on communication, pressure testing, timing, and support. These are traditional clinic structures that I think you would find in just about any medical group, and it's critical that they weigh in on those operational issues, and once again, that they help own it. It wasn't us doing it to them, it was us doing it with them, and how could they help us be successful to meet our patients' needs. So importantly with that, we felt like the physicians needed to be the owners on all the operational projects. So when there were presentations or communications that needed to happen, those came directly from physician colleagues. And I think it really positively influenced the pace and adoption of change in the medical group. So I've truly been shocked that we're now in April and the amount of chatter in the background, et cetera, has really been minimal. And I think a lot of that is due to how we marry the two processes to work on access and engagement at the same time. Brent, do you think this mirrors at ProHealth what you've seen in your broader experience?
Absolutely, and I think ProHealth is one of the best examples I've seen of utilizing existing physician leaders and then engaging additional physician leaders, particularly around the project work associated with patient access improvement, to get results in a timely fashion. And having physician champions that can wrap their head around the full scope of the issues and then bring other physician leaders with them that filters down through the organization. I don't think any of the physicians within ProHealth are feeling like patient access solutions have been pushed upon them so much as they've been able to partner and make some decisions, as Mary said, that improve access to care for their patients and ultimately improve the way their practice is managed. In many cases, it's led to higher physician satisfaction as well. One of the key things, if you'll click to the next slide, Molly, that coming out of the gates with any type of physician access initiative is demonstrating the problem or the issues. And a lot of times physicians are either too ingrained in their own practice or unaware of the full scope of patient access problems to really jump on board immediately. And so there's usually some convincing that goes on. And when we started to pull the data and show a group of providers in a room what kinds of restrictions and barriers to patient access the organization was dealing with, it became so apparent that they were up in arms telling us, well, we got to do something to address this, and maybe we need to start completely open access scheduling tomorrow. And so quantifying that problem, demonstrating the opportunity, I think is a key ingredient for gaining physician buy-in early to get them thinking about how we're going to solve those issues. And Mary and her team just did an exceptional job putting that together. And the slide you're looking at here is an example of some of the data that we used early on to say there are problems with patient access, and whether it's you specifically as a physician or your partners and peers, these are some of the things we've seen come out, whether it's unbookable minutes in a single week, seeing all that time added up, or providers that have closed practices in the upper left-hand corner who are producing below or well below MGMA median. All that unbooked time and those restrictions, not seeing new patients on certain days of the week, et cetera, helped convince early on those physician leaders that something had to be done. And then once we had their full buy-in, they were a partner along the way. And that early engagement is key.
Thanks, Brant and Mary. So something I've picked up on so far in our conversation is how patient access strategies and any improvements must really be sustainable, and how this is really an ongoing effort for hospitals and health systems. So Brant, can you talk a little bit more about how organizations can effectively monitor and manage patient access?
Absolutely. So we just talked about using data on the front end to quantify the problem and demonstrate the opportunity. Once you've demonstrated the opportunity and put solutions in place, it's important that you're able to track and measure the successes and the potential failures or shortcomings so that you know where to put additional resource and energy. We, as I mentioned, track financial benefit and operational benefit side by side. And so as you want to get return on your investment, which is important for these solutions, it's also key to support that with other data, as we said earlier. And so if we look at the next slide, Molly, we've got a couple of examples here of some of the service access metrics that we're using at ProHealth and that we see across the country for painting the full picture of patient access issues. And so these are in the top there, you've got several key metrics for patient access, from productivity to unbooked hours, no-show and cancellation rates, and slot utilization. All of those metrics together really help inform at the practice level, and then as you dig deeper into it, the individual provider level, where there is additional opportunity or which metric need additional attention. Similarly with the patient satisfaction data that Mary mentioned earlier, from a baseline to just after 2 months after implementation, we were able to see a significant change in patient satisfaction scores. And while those alone don't indicate success across the board for patient access improvement, that paired with the operational metrics above helped to tell the story that, yes, we're seeing not only an increase in productivity and some financial gains here, but this is working for us operationally. And so we like to put all this together and use it at the executive level and then at the provider and clinic level to engage them in the data and have established targets that we're working on together and celebrating the successes and putting additional resource where it's needed. Mary, if you want to talk about the next slide, we have a few examples of how ProHealth has seen specific impact and gains.
Sure. ProHealth obviously has partnered with Brant and his team on how to meaningfully impact access and service. And what that's resulted in is giving our administrative leaders and providers the tools to support their processes. I feel we're really successfully positioned to support lasting change. Managing access requires daily blocking and tackling. It's cultural and it's operational. Our efforts have allowed us to weave it into our existing workflow, so it's not something separate we do. It is part of who we are and what we need to do. The graphic on the top left is probably one of my favorites as a tool, because it lets us see how we're managing and monitoring from our baseline our improvements in our third next available. And your screen really demonstrates that improvement we observed with over an 80% improvement in new visits, which was the most impactful. And recognizing that a source of new growth is essential for any practice, that was really gratifying to see that level of improvement. The graphic on the right side of your screens are a really interesting visual, just kind of depicting that conversation where Brant shared we had those 13,000 new slots and visits that were created. Gaining those extra minutes really was a key factor in being able to recapture those minor appointment volumes that had drifted to urgent care. And it really also eliminated some of the rework that was going on behind the scenes as people were double booking around the process to try to squeeze these minor appointments in. And then finally, the graphic at the bottom, it's an illustration of how immediately we were able to see that improvement happen once we hit our go live on the new templates. Our go live date was January the 9th, and as you can see from the baseline week to the last 2 weeks, there was a substantial improvement at ProHealth in our visit volumes for both new and existing patients. So from our perspective, the real key takeaway here is from this section to continuously measure, monitor it, and adjust it as you need for what works in your organization. And a core set of tools to support that visual management of the program really lets all levels of the organization be engaged. So it's great to make sure that your senior executives are aware of what's going on, but we have found all of these tools to be helpful in talking to the staff, the physicians involved, engaged, as well as those operational teams we shared earlier. So Brant, any final thoughts?
I think that's great. Well said, Mary. And ultimately, the patient access issues, while we've talked a lot here about the high-level systemic change and the results globally across ProHealth's enterprise, this is a daily blocking and tackling effort and initiative. And so putting in place the rules of the system and the game for providers and patients and staff is a critical step in that process. But ultimately, you're setting up a system where that daily operation and management is successful. And I think that's what ProHealth is just seeing the benefits of here early on, almost immediately after some implementation work, and we'll continue to push on these metrics and on the solutions moving forward.
Thank you, Brant and Mary, for that fantastic presentation. So we're now going to begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled "Enter a Question for Staff" and clicking Send. We will try to get through as many questions as we have time for today. So Brant and Mary, the first question that came in is, can you review the definitions of the items on the practice assessment tool? And Mary and Brant, we're going to pull that back up here, that slide. So can we review these metrics a little bit more specifically so attendees understand exactly what you're measuring here?
Sure. So the RAF score obviously is only published so on a specific ratio. It's really the HCC information that most institutions have access to that lets us know the complexity or acuity of the patient. When we really looked at what the RAF score, HCC scores were ranging in our organization, they were predominantly well below 1. We had a few people that were higher. We originally started with a range slightly larger than this, but after looking at it, scaled back and said, okay, here's the benefit to you, because not only can we know how busy you are and whether your practice should be open and closed, but this tells us the acuity of your patients. And if you have a really higher RAF score and some other metrics on this same page, it may mean that you actually need other resources to help you manage your patients, such as an MA or a part-time MA. The number of visits per panel is how many visits a patient sees. So let's say we have a provider that has 2,000 patients in their panel, but they had 3,000 visits. That's a ratio of 1.5. So it's the frequency on average, just at an aggregate level, patients are coming back in. Many providers who have a high acuity RAF score, HCC score, will have a really high visit per panel, and then that means those patients with those comorbid conditions are coming in much more frequently. Patients over 55 is just very basic. What component of those are going to most likely be comorbid, and what percentage is Medicare and Medicaid, because many of those patients have some special social determinants that they're needed. The cut points are rather arbitrary for both of those two. We found very little data in the literature that we could use as a benchmark, so that was really from a consensus-based process of our team. The functional panel size then is actually a calculation of those top 4 things that takes into consideration the illness level of the patients, the visits per panel, and those over 55 Medicare, Medicaid. And then we're pulling just your traditional third next available for a physical and a 30-minute follow-up from our contact center. What are we seeing out of that, and what's the range of those? And then lag time, which of course is more of a reflection of what you offered the patient versus what appointment did they pick. And so most institutions are working some type of lag process to give people the opportunity to move up.
Thank you so much, Mary. Brant, I believe this next question is for you based on the remarks you made about consistency. And this one says, you mentioned moving to a centralized environment. Is this a central scheduling function? Does it include other functions such as referral coordination? What benefits have you seen by shifting to this type of environment?
Great question, and one that many organizations are dealing with today, particularly as they grow. Whether you centralize formally or informally, I do think that pooling resources is becoming key to not just to manage the daily objective, but to backfill as people are out or as systems change or providers come and go. So in ProHealth's case, they put together a centralized contact center where they have a building of people who handle phone calls and scheduling for the entire enterprise. At a smaller level, and I've seen this be just as successful, pooling nursing resources among several primary care clinics where all triage goes to a central triage bucket or phone line that these nurses can work together gives you greater scope and better ability to adjust for volumes and manage that work on a daily basis. The same would apply for front office functions or for rooming, Team MA and pooling providers into pods in certain buildings, having central registration desks for certain buildings. basically trying to benefit from the size of your organization as opposed to fighting it is what we've seen, and why we say to some degree centralizing. But it doesn't have to be a formal call center where you move bodies into a new building or their own space. You can virtually centralize and get some of that same value.
Great, thank you, Brant. And this will probably be our last question of the Q&A portion, but we had two questions come in that are related, so I'm going to pose them both to you. The first is, how did you get over provider resistance on manipulating their schedules? And the second is, how do you hold providers accountable when they do not follow schedule changes? So Mary or Brant, I pose that one toward either of you, if one of you has some thoughts on that.
So to me, once again, it goes back to we're doing this with you and not to you, but we have to have some type of concept that's going to meet the patient's needs both now and the future. We know we don't have access. We know we have to do a better job at that. We have to make it easier for the people trying to schedule the appointments. And I think, as Brant alluded to earlier, putting them in a room and showing them real life examples of what our schedulers are facing, especially in that centralized environment. When they were living in their own clinics, as Brant said, when you acquire people, they come over with a lot of the practices that have historically people have had. And Susie Joe at the front desk or the PSR always did it that way because they had a great rapport, and that's wonderful. But as you grow and expand, that's not a sustainable model anymore. And so they really understood by looking at each other's templates, well, nobody could do that. So as Brant said, they were ready to say, you can't have any restrictions. And we said, no, that's probably not going to work for the medical group as a whole. People need to have some input to the processes. So let's make sure that we give them the ability to see all of the key types of appointments. And what we will give them flexibility on is, how do you want to see those organized in your day? Do you want your same day slots all in the beginning? Do you want them spread throughout the day? Do do we want to keep your physical appointments that we hold not combined or separated? So I think that's what gave them what they needed, so they felt they had choice, but without having it being so restricted and standardized that it was something they couldn't partner with you on.
Yeah, I agree, and think that one is demonstrating the complexity, because many providers don't understand it, and you will have opposition. There will be people that say, I don't care, providers that say, I don't care how big of a problem this is, I'm not willing to give up my template or my algorithms and schedule. And there eventually has to, part of the reason that physician partnership is so important is you don't want this to be something that your local frontline leaderships, your clinic managers and supervisors have to enforce on a daily basis. So as you get that direction and decision group-wide or system-wide from physician leadership that this is what we're going to do as a system, because it's what's best for our patients and for our operation, then you can push that in an objective way and take it out of the hands of a local MA or nurse to say no or yes to a physician, and monitor that at a central scheduling level. As Mary said, only quarterly can a provider adjust their template or their visit links or something that requires a technical change, and they can monitor in the system the adjustments and see if there are additional blocks being put on provider schedules and that sort of thing. So we try to take it out of that front line, because you'll never get results if that relationship is stressed between the staff and the provider in the hallway.
Thank you, Brant. Thank you, Mary. So this is all the time we have for today. I want to thank Brant and Mary for their excellent presentation, and to our audience for participating today. Hope you enjoy the rest of your day, and we look forward to having you join us for future webinars. Thank you.